Steph Garte, who has been chairing these masterclasses till date and done a fantastic job. So I'm really looking forward to chairing in the future as well, and open to any ideas. If anybody would like to present in the masterclass, then please contact me. You've got my Twitter feed there. And I just wanted to take this opportunity as well to ask all the delegates, to join our METS Optimization Digital Network. It's an NHS Futures page. The benefit of joining this network is that all the slides from our masterclasses, the slide decks, will be uploaded there. Any sort of questions that our presenters are unable to answer for time reasons will also be uploaded there. We also have the Community of Practice discussion forum where like-minded individuals can discuss anything they would like regarding digitalization of medicines, potential future topics. So please do join the network. I will put the details in the chat. So we've got a really good turnout today. I just wanted to say I'm really excited for today's session. We've got 3 really esteemed speakers, so honored to be here with them, really. So today's theme for the ePrescribing Masterclass will be around antimicrobial stewardship in conjunction with World Antimicrobial Awareness Week, which is happening next week. We will be starting with setting the scene really about the threat of antimicrobial resistance. So Tanya, who is Chief Pharmaceutical Officer's Clinical Fellow from the UKHSA, will be starting with that. After that, we will have Dr. Louise Dunsmore and Doug Izzard, along with Tague Parsons, who will be talking about ePrescribing, how ePrescribing enhances antimicrobial stewardship. And finally, as we go through the journey of understanding the tools that we've got, we'll have Laura Whitney and Connor Jamieson, who are regional antimicrobial stewardship leads in the London and Midlands. They'll be talking to us about creating a digital vision for antimicrobial stewardship. As always, my request is please put any questions that you've got in the questions tab. I'll do my best to get around to to posing these questions to our speakers. And without much further ado, I am really excited to be inviting Tanya to start with the first presentation to tell us about the global threat of antimicrobial resistance. Tanya?
Hi everyone, Sangeeta, can you hear me okay? Fantastic. Hi everyone, I'm Tanya. I'm one of the Chief Pharmaceutical Officers Clinical Fellows based at the AMR program at UKHSA. Could we just go on to the next slide, please? So in honor of World Antimicrobial Awareness Week, I'm here today to talk to you about the global threat of antimicrobial resistance. The wonderful speakers after me, as Sangeeta has already mentioned, will be talking about ePrescribing and digital visions for antimicrobial stewardship. So hopefully my talk will set the scene a little bit and lead somewhat nicely into that and give you a bit more information. Next slide, please. Antimicrobials save lives. We as healthcare professions already know and appreciate this, and life as we know it just wouldn't exist without them. We all know the story of Alexander Fleming coming home from his holiday to find mold growing on a petri dish of Staphylococcus and discovering penicillin and starting off a wonderful antibiotic revolution. And how privileged we are to have been alive and living in this world where a common infection won't usually kill us off. Antibiotics save so many lives and on average contribute an additional 20 years of life expectancy across the world. And we also have antivirals, antifungals, and antiprotozoals all working against different infections to save our lives. However, with this came some danger, and Alexander Fleming knew the dangers of overuse. So I'd like to read you a little quote from his Nobel Prize acceptance speech in 1945, if that's okay. And it is, "The time may come when penicillin can be bought by anyone in the shops. Then there is the danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug make them resistant." Next slide, please. And how right he was. So resistance to antimicrobials occurs when infection-causing organisms develop methods to survive treatment, becoming resistant. So previously we used to refer to it as antibiotic resistance, but the term has now expanded and we use antimicrobial resistance as a broader term because it also includes antibiotics, antiprotozoals, antivirals, and antifungals, as we mentioned before. Now, resistance is a naturally occurring biological phenomenon, but it is increased and accelerated by inappropriately using antimicrobials, poor infection control and prevention practices, as well as global trade and travel. Resistance is one of the biggest threats facing us today. The World Health Organization has declared that it is one of the top 10 global public health threats facing humanity today. Next slide, please. So we know that antimicrobials are becoming increasingly ineffective as drug resistance spreads globally, and this is leading to more difficult to treat infections and subsequently death. So this is a big concern with antibiotics for treating bacterial infections. Many of the medical advances in recent years, for example, organ transplantation, cancer chemotherapy, they all need antibiotics to prevent and treat the bacterial infections that can follow treatment. And without effective antibiotics available, even minor surgery and routine operations can end up becoming really high-risk procedures. The World Health Organization have predicted that left unchecked, antimicrobial resistance could cause an additional 10 million deaths by 2050 and cause 66 trillion. And the question remains, which threats are the most imminent, and could it be too late to try and avoid some of these disasters? You will know about the development of the superbug. We've all heard of them. These are strains of bacteria, viruses, parasites, and fungi that are resistant to most of the antibiotics and other medications commonly used to treat them. The list on the screen on the right-hand side are examples of superbugs that are causing problems globally and are very difficult to treat. They're very serious in medical emergencies that require lots of intervention, time, and resources to manage, and are not always treatable, leading to devastating consequences. Next slide, please. Aside from superbugs, is it possible to become susceptible to diseases that are currently treatable due to the increase and rise of antimicrobial resistance? In a nutshell, yes. High rates of resistance are frequently used to treat common bacterial I've lost my train of thought. High rates of resistance against antibiotics frequently used to treat common bacterial infections such as UTIs, sepsis, STIs, and even some forms of diarrhea have been observed worldwide, and indicating that we are essentially running out of effective antibiotics. For example, the rate of resistance to ciprofloxacin, commonly used to treat UTIs, varied from 8.4% to 92.9% for E. coli, and from 4.1% to 79.4% for Klebsiella pneumoniae in countries reporting to the Global Antimicrobial Resistance and Use Surveillance System, known as GLASS. There are many more examples of the rates of resistance increasing, and treatments we take for granted now are more than likely to become ineffective in the future without anything else available to replace them. There's much more statistics available on the World Health Organization website if you are interested in knowing a bit more about that, and many other resources as well. Next slide, please. So this is why the world needs to take action now. There are potential solutions that can help mitigate a number of threats at the same time, and these are antimicrobial stewardship, change, innovation, and working together. Antimicrobial stewardship is a term that refers to an organizational or healthcare system-wide approach to promote and monitor the safe and appropriate use of antimicrobials to preserve their future effectiveness. So the diagram on the screen demonstrates a number of initiatives in the fight against antimicrobial resistance, and this includes the promotion of infection prevention campaigns, raising and developing awareness, developing diagnostic tools for rapid and reliable detection of resistance, pushing and promoting vaccination programs, setting up antibiotics surveillance programs across the world, improving waste management and water sanitation, and very importantly, funding and encouraging new antimicrobial development through innovative planning and incentive schemes. So as you can see, to protect antimicrobials, we really need a comprehensive, uniform, and coordinated response from countries all over the world. Next slide, please. So what is out there in terms of national antimicrobial stewardship tools? Here in the UK, we're really lucky to have many different organisations working tirelessly in the fight against antimicrobial resistance. And off the back of that, we have a wide range of useful tools and resources that are available to support us in our day-to-day roles. This diagram represents some of these, which I've no doubt you will have either heard of, used, or experienced throughout your roles. Next slide, please. I could have spent forever talking about the different resources, but we've picked out a fair few. So on this slide are some useful resources nationally available to all of those in healthcare to help promote and practice antimicrobial stewardship. So Start Smart Then Focus is a really well-known and established toolkit from UK HSA that provides an outline of evidence-based antimicrobial stewardship in the secondary healthcare setting. It's become so embedded in practice that many countries all over the world have actually adopted it into their national policy. The Start Smart Then Focus principles are really integral to antimicrobial stewardship and ensuring that we are using them appropriately in practice. And the benefit of them is that they're really simple, easy to understand, to follow, and really relevant across practice. They're there on the screen in case you wanted to take a look, and they're in the process of getting kind of updated for the future as well. Other useful resources include the e-learning for healthcare, resources to support clinical and non-clinical staff in understanding the threats posed by antimicrobial resistance and the ways that they can help to tackle this major health issue. This program was developed by HEE in collaboration with the UK HSA, NHS, CQC, NICE, so all the famous people. And there's a plethora of resources, modules, and teaching sessions within the program which are actually really well received. And as a personal advocate, I really found them useful as well. Another example of an established resource is the Dental Antimicrobial Stewardship Toolkit, which is hosted by UK HSA, and that also contains many resources to help primary care practitioners to promote the appropriate use of antibiotics in dental care, issues that some of us might not have thought of, but it really does span the entire healthcare organisation. Next slide, please. And this is a really useful thing to talk about, TARGET. So TARGET stands for Treat Antibiotic Responsibly Guidance Education Tools, and it's a toolkit which includes a range of free resources that can each be used to support prescribers and patients' responsible antibiotic use. It's a central resource to help primary care healthcare professionals and commissioning organizations improve antibiotic prescribing. And actually using the TARGET toolkit resources enables primary care organizations to demonstrate that they are complying with the Health and Social Care Act of 2008, the section which is a code of practice on the prevention and control of infections and related guidance. Target also now hosts the new how-to resources for health professionals in primary care, and this is a series that aims to support primary care teams to review appropriateness of antimicrobials in the evidence-based treatment and prevention of acne vulgaris and COPD. Next slide, please. In terms of national guidance available, NICE is where you should really go because they've got a whole suite of guidance in antimicrobial stewardship and managing infections safely and appropriately. The diagram on the screen demonstrates the different infection scenarios on which guidance is available, and on the right is a snapshot of what you might find within. So this is for COPD acute exacerbation management, and what's useful is they provide all the antimicrobial recommendations and tables and also some really handy flow charts for treatment algorithms, so it's good to know about where to direct people for that. Next slide, please. So UK HSA, my employer, have several different teams working away in the background to help positively contribute in the fight against antimicrobial resistance and promotion of antimicrobial stewardship. So gov.uk hosts all the advice and recommendations published by UK HSA and is again full of really useful resources for healthcare professionals and the general public. There's absolutely reams of it, so definitely check it out if you get a chance. NICE and UK HSA have worked to combine together their information on managing infections to make it easier for healthcare professionals to access. And this is really straightforward and clear to navigate as well. It's definitely useful to be aware of and let your colleagues know that it's available as well. And I always think it's easier to have information in one place, which is always good. Some new work to come out of UKHSA, and something you may want to check out if you get a chance, is the National Antimicrobial Intravenous to Oral Switch criteria for early switch. So this was co-produced through a UK-wide consensus process involving 279 multidisciplinary participants, and there's 5 different sections: timing of intravenous and antimicrobial review, clinical signs and symptoms, and so on. And each point, there's points within each criteria which help a prescriber decide whether an early switch to oral is appropriate, and I think it will be really useful in clinical practice. So next slide, please. So what can everyone do? That's the end of the snapshot into big national guidance that is available. But to be fair, that's only part of the story in reality. To make a big difference in the fight against antimicrobial resistance, we need to begin at home and with the people around us to change beliefs and attitudes and to help everyone understand the bigger picture. So what little things can we all be doing at home, and more importantly, advising our friends, families and patients to do also? We now know that addressing antimicrobial resistance requires a coordinated effort from absolutely everyone, including the general public. The best thing anyone can do is to prevent infections from spreading in the first place by washing their hands, avoiding contact with sick people, and staying up to date with their vaccinations. If they do get an infection, we should advise them to only take antibiotics if they've been prescribed by a qualified healthcare professional and there's no other treatment options. They need to make sure they complete the full course prescribed to them, as we know, that sometimes people can stop them when they start to feel better, and this contributes to increased resistance. We need to avoid being reluctant to tell them that, just keep reminding them to never use any leftover antibiotics from old courses, making sure that they are disposed of properly to avoid them getting into places they shouldn't be and increasing exposure, and reminding them to never share antibiotics with others, such as family and friends. Some of you may have seen a lot of media talk about politicians sharing antibiotics, but please remember that we, as healthcare professionals, do not recommend this. There are things we can all do in the fight against antimicrobial resistance, and education, awareness and understanding here and across the world is really vital to make a true difference. And while you're here, I might just plug, consider signing up to be an antibiotic guardian if you already aren't. So we're a community of individuals and organisations who've taken pledges to make better use of antimicrobials and help save these vital medicines from becoming obsolete. And as a personal plea from UKHSA and everyone else involved in the fight, please share things you see posted during World Antimicrobial Awareness Week to spread the word and get everyone talking again about this important topic. Because as someone who's come from practice recently, sometimes it can seem a challenge too big to even consider, but everyone taking their role is what's going to make a difference. So next slide, please. Thank you so much for your attention, everyone. I hope you can all take something away from this, and if anyone has any questions, otherwise, thank you to Sangeeta for letting me speak.
Thank you, Tanya, for that lovely presentation. I think it's given us a lot of food for thought about the threat that antimicrobial resistance brings to all of us. I think it's quite staggering that the number that you've just provided, 10 million people will be dead by 2050. So that really gives us a lot to think about in terms of being a professional. I just wanted to pose a question to you, if I may, Tanya. One of the questions that we've had asked was, how can we pave the way for new antibiotic development in the future?
I think this is really, really important. And one of the things that I've kind of learned about since working at UKHSA is the presence of this negative feedback loop. So due to antimicrobial stewardship, we end up getting fewer antibiotics prescribed, which means drug companies end up putting their resources and investments into other therapeutic areas because obviously they're more financially lucrative. And then because of that, there's only a handful of drug makers that are working to develop these needed antibiotics. So that's why industry, governments and organizations are actually having to work together to ensure that there's a sustainable pipeline of new drugs coming on the market. And there's actually some really interesting models, and one of them was like implementing market entry awards. So you give lump sums to people who are successfully developing new antibiotics with the premise that more will come later. And the UK actually has become the first country to launch a new, people call it the Netflix model. So it's the new subscription system, which there's a lot of information available at NICE, which trials paying pharmaceutical companies for novel antimicrobials based on their value to our NHS and wider society instead of how much we're actually using them. So it's like they're guaranteed money on the premise that we will access them when needed and not on how much they're selling, which kind of changes the way we look at it a little bit in terms of the current market. So subscription models like that are really good incentives to try and develop new antibiotics, and because the drug companies are basically going to get their money regardless of how much we use them, because we want to use them less to preserve their use. So it's counteracting that negative feedback loop, if that makes sense.
Oh, thanks, Tanya. I think that's really important. It's a very innovative solution to a problem that we've had for quite some time. There is another question, but I will save that to be answered on our Excel spreadsheet, which will be uploaded on the network page only for time reasons. So thank you very much, Tanya.
Thank you. Thank you. Thanks, everyone.
Thank you. I am really pleased to be moving on to our second presentation, where we've got Dr. Louise Dunsmore and Doug Izzard, along with Teig Parsons, who will be talking about how ePrescribing can enhance antimicrobial stewardship. So without further ado, please may I welcome them. Thank you.
Thank you so much for the opportunity to talk to everybody today. Much appreciated. And Tanya, thank you for a really informative presentation to start us off. One of the key things I think your messages you were delivering there is about optimizing the use of antimicrobials to make sure that we protect the antimicrobials for when they're actually needed. And you alluded to the start smart then focus and also the importance of guidelines. But one of the things we really wanted to do for you today was to show the importance of electronic prescribing, whether that's the records or the administration records, and how they can help support the stewardship agenda. For those of you that have heard us speak before, we're not actually going to talk to you today about our build and how that actually happened, but at the end we do have contact details if you do want to speak to any of our EPR colleagues. What we want to do is to show you some practical aspects of how ePrescribing enhances antimicrobial stewardship. So my colleagues Doug and Teig are going to be delivering the session, although I've just heard that Teig is unable to join us because his app has crashed. So actually, if we can move on to the next slide, please, Sangeeta, I will hope and be able to take this forward. So as I said, there's myself, Doug and Teig. Unfortunately, our colleague Bernadette was unwell, so was at the last moment being unable to join us. So next slide, please. Thank you. So Doug is going to talk for most of this presentation, but the real things that we're wanting to talk about here is from principles to practice. So we're talking about the importance of visualizing data. If you can't measure, then you can't improve. And also we're going to talk about ensuring safety. So there are our three themes that are going to run throughout the presentation. So next slide, please. So the first thing that my colleague Teig was going to share with you is something that's actually been built, and our stewardship lead, Dr. Nicola Jones, is actually on the line with us today. So hi, Nikki. So one of the things when we first started to address the stewardship agenda and work out how we can actually help people have access to information, we built this platform on our Orbit Plus, which I think many of the NHS institutions actually have. And this was a way of extracting information from the EPR back door or the warehouse to actually find out information about the number of prescriptions for each antibiotic. At that point we started with antibiotics, and also looking at the number of administrations for each individual agent, and we were able to then actually provide and present that information back at a division level and a directorate level, also at a speciality level, but even more specific down at an individual consultant. So you could compare, for example, a cardiologist who prescribed X antibiotics with another cardiologist that was presenting Y. And this was the mainstay of our sort of ability to do feedback for quite a while. And it worked well, and it was on a rolling trend, but then our colleague Teig was able to prepare something different. So if I could have the next slide, please. we have a heat map. And so this heat map is relatively new in our sort of arsenal of actually finding out more information about our uses of agents, and actually it's gone more broader. So as Tanya alluded to before, there's very specific definitions about antifungals, antibiotics and antimicrobials, and this heat map actually looks at antimicrobials more broadly. So we've got the antibiotics and the antifungals there, and by looking at this we can see on a month-by-month basis. Oh, Teg's back. Teg, would you like to take over from your heat map? Unable to speak. Okay. I'll carry on. You can tell me though if you can give me the sign if I'm doing something terrible wrong. So as you can see, we can now compare on a year-by-year basis, on like a month, each month and the year before, to see how we're using each individual agent, and that again has given us a signal to see whether or not we're using more of X agent or Y agent. As you can see, we do like a lot of coamoxiclav over here at OUH, and that is always the top band in there. But by actually having access to this information, it's allowing us to provide feedback to the prescribers, and it's only because Teg is an information analyst who's actually been able to help us develop this. So one of the key things I recommend for any antimicrobial stewardship team that you're assembling is to have an information analyst, because they will be able to take your work to the next level. Thank you. Next slide, please.
Quick question, can you hear me now?
Yes, we can hear you, Teg. I'll hand over to you, sweetheart.
Thank you. One last thing about the previous heat map. You can very clearly see where we'd switch to copazolin right at the bottom there. So you can start to see sort of pinpoint the impact of antibiotic changes in practice. Next slide, please. So a rather unique boon of our electronic prescribing system is that we're using this data to interface with an online tool called NAPS. So NAPS is the National Antimicrobial Prescribing Survey, I think I got that right, which is an Australian-based point prevalence survey system. So it allows us to provide kind of impactful reviews on our day-to-day antibiotic prescribing compliance and our appropriateness for certain antimicrobials. So we report on that quarterly, and it looks something like what you can see on screen. So what we've done is we've built an internal tool that takes our EPR data and sort of auto-validates it into the necessary format for the NAPS platform. This, in essence, makes uploading the data to this platform virtually seamless. Then what we have is pharmacists or other clinicians then review prescriptions, and then the platform spits out the report like the excerpt that you have on screen. Next slide, please. For further insights, we also export that process data. From there, we can then look at problem trends. So for example, here we looked at suboptimal prescribing in terms of agents and treatment sites. The results of that can then also help us drive change with clinical practice. Next slide. Lastly, at least for this presentation, in terms of visualizing data, we have one last use which we've been progressing, which is the use of clinician-specific reporting. This will help encourage taking ownership of one's own data. So here we have a snippet of a few of the metrics that we've been using. So administrations per admission, the share of prescriptions that are broad spectrum agents, and comparing ratios of one agent to another. All of these help consultants get a clearer view of their prescribing habits, and also, as a bonus, to compare themselves versus their peer group. So that's a look at some of the tools that we have in our trust. Thanks.
Do next slide, please. Lovely, thank you. So I think Tanya really nicely highlighted what we need to do, and I want to talk to you about how we're doing it locally, and more importantly, how ePrescribing is allowing us to do that. So one of the key themes really is we need to break it down to, if you can't measure it, you can't improve it. So if I don't know where broad spectrum usage is, or who is on broad spectrums, then I can't do much as a stewardship pharmacist to try and reduce that. And through our electronic prescribing system, we're able to pull real-time patient level antibiotic usage. And that's really useful because it allows us to specifically target these patients in these wards during our stewardship rounds. And so it allows you to come in some ways armed to those conversations with the clinical teams, where you can say you have this patient on this antibiotic, this patient on this antibiotic, etc. And it's really good for facilitating those conversations around possibility of kind of de-escalating or switching to oral therapy. And going further, we're able to tailor those reports to what we want them to do. So I've included just a very small number of examples of some of the bespoke reports that we've produced locally. And we have an adult stewardship report, for instance, which is kind of the bread and butter of my work, and that's the one I use when I go on these stewardship rounds. The pediatrics team have produced a very similar one, and then we also have some other ones which you can see there. And I'd like to draw your attention to the table on the right, which is some data that we presented to our Infection Prevention and Control Committee. And really, I think some of the key takeaway points from this is that in 1 year, we've reviewed just over 2,000 patients, and we've made 1,307 interventions. And really what I'm wanting to really drill down on is that I don't think these huge numbers would have been possible without our e-prescribing system, but the ability to pull that real-time patient level data is what makes us really efficient on those ward rounds, and it's what really helps us identify those patients who are maybe amenable to interventions. Next slide, please. So as I just mentioned, we think that the ward rounds have been really successful, and they've been so successful that we're aiming to duplicate those on different hospital sites, and we're also aiming to increase the number of ward rounds, especially with pharmacy involvement. Some other uses of this pulling of live data is we have just in fact implemented a vancomycin and meropenem monitoring system at our quaternary orthopedic hospital, where we use a lot of post-operative vancomycin and meropenem, and this project is all about promoting both sufficient monitoring for those, but also that they're stopped and reviewed at appropriate times, and we're hoping that we're going to see some good data from that. A big quality of life improvement for me as one of the stewardship pharmacists is being able to harmonize how all those reports from all of our different stewardship rounds pull, and that allows us to import those into a stewardship database where I will directly record the interventions that I made. And so it both reduces duplication of effort, reduces transcription errors, and it builds on that previous efficiency savings that I've spoken about. But also that's a really powerful tool in feeding back to stakeholders, because that data that I showed you on the previous slide, we're hoping to build on that and demonstrate it on more and more sites, and that helps build momentum for the service that we're providing. If I can have next slide, please. So I've just included some screenshots just to show you how our raw data is actually pulling from Discern Analytics. So I've anonymized it, so we've removed patient data and we've removed the consultant, but you can see, I hope quite clearly, why these are quite powerful tools, because we can immediately see the usage in this case of broad spectrums for certain wards. Next slide, please. Thank you. And this slide here, this is just to highlight that although I've focused a lot on that live data, we are also able to pull retrospective data. So this is what we're using for our COVID therapies report. So you can see there that those discontinued ones, patients have already had those, but we use this to audit our funding approval and our blue tech rate. Next slide, please. Thank you. So on the left here, I've just included this to show you kind of the really wide range of pre-built reports that people are using. You'll see that quite a lot of them are antimicrobial stewardship focused because we really like them, but there are also other uses. And on the right here, I've just included a screenshot just to show that you don't have to use these pre-built reports either. So if I wanted to, for instance, look at ceftriaxone, kermoxiclav and ciprofloxacin usage, I could run that for any number of sites that I want to, and I could look at different patient types. And that's quite useful, both if you're scoping out maybe increasing the number of antimicrobials you're including on a ward round, or if you're wanting to maybe suggest trying to implement ward rounds on other locations, which I've certainly used. Next slide, please. So I'm aware of time, so I'm going to skip through a few little bits. In terms of ensuring safety, e-prescribing is really essential for our team in ensuring safe use of our antimicrobials. I've mentioned a little bit about our audit processes, specifically around the COVID therapies, but we do use it for other processes. Governance is always a consideration. And I'd like to move on to the prescribing decision support, because that's a really big area where our team's involved. So if I could have the next slide, please. So we have over 70 power plans in our trust, which include an antimicrobial, and I've included just a small list there. But really what these allow us to do is highlight our antimicrobial guidelines and try and get them to be used as much as possible. And they're really useful for promoting effective renal dosing, for highlighting when dosing might be different for different indications, but also for encouraging appropriate drug level monitoring. So if we could have next slide, please. So I've included just a few quite pertinent examples that I think really exemplify some really good power plans that show those principles. So our teicoplanin one, you can see we have our different dosing regimes based on deep-seated and non-deep-seated infections. These power plans will automatically calculate a patient's dose based on their weight. So for instance, this patient is between 75 and 89 kilos, which is how it's come up with that weight. And importantly, it will automatically calculate the appropriate intervals between your loading and your maintenance doses. So if you have an on-call doctor prescribing a dose of teicoplanin at 3 AM, this will correctly adjust your intervals, which is really good. Next slide, please. Vancomycin, so this really covers a lot of the same principles as the teicoplanin, but one of the key areas I wanted to highlight with this one is right at the bottom. You can see that we've pre-built in the request for a vancomycin trough level. And so again, that will help ensure that that's taken at the correct time and the vancomycin monitoring is performed correctly. Next slide, please. Thank you. And then my final example is ceftazidime avibactam, where I think this really perfectly exemplifies some quite clear renal adjusted dosing. You have to prescribe ceftazidime avibactam with this power plan. So we're trying to make it as hard as possible for someone to unintentionally prescribe the right dose and really promote careful consideration of those renal doses. Next slide, please. Thank you very much. Apologies for flying through those slides at the end there, but I'm just aware of time. As Lou mentioned at the beginning, if you do have any queries focusing on the stewardship side, please do use that first email. And for more informatics coding queries, our colleagues are more than happy to help on the second email.
Thank you, Doug, Louise, and Tig for that fantastic presentation. I think it's really important, while we understand what the threat is, to find tools so that we can minimize this threat to us. It's very impressive, the bespoke reports that you've created. We've had quite a number of questions, so I'm just going to put one to you just for time reasons, if I may. We've got a question of how do you assign prescribing to a consultant, given it is often done by a junior staff?
Doug, do you want to take that, or shall I?
I think if you're happy to, you're probably better answering it than me.
We use it as the consultant, the named consultant assigned to that particular patient's case. So we do understand that Dr. X might take the care in ED, for example, and then they might move to a different firm, so to become Dr. Y, etc. So it's the consultant that the patient is assigned to at that time where that antimicrobial agent is used. So it does reflect the change in the speciality. So for example, if they were endocarditis, went from ED to EAU, from ED, EAU, and then cardiology, then the bulk of the endocarditis treatment would be assigned to the cardiologist, for example.
Brilliant. Thank you for that, Louise. Once again, thank you for the time that you've taken to create this brilliant presentation and providing your contact details as well, so that our colleagues can get in touch. Without further ado, I will move on to our third and final presentation for today, which will be presented by Connor Jamieson and Laura Whitney. And the presentation is about creating a digital vision for antimicrobial stewardship. Thank you.
Thanks very much, Sangeeta. Can you just check you can hear me okay? Oh,
yes, we can.
That's a yes. Yeah, lovely, brilliant. So delighted Laura's solved her IT issues and is able to dial in. So we have presented on this in the past, but I think the presentation that Tanya gave at the outset really explains what antimicrobial stewardship is and how complex it is and how many stakeholders are involved in it. And then Louise and Doug and Teg have given a really nice example of building, using digital tools for enhancing an antimicrobial stewardship program. So that's going to allow me to skip over some of the slides in a little bit less detail, just because of the interest of time. Next slide, please. And the next slide again, thank you. So I won't spend any more time on explaining what antimicrobial stewardship is, but I will just explain a little bit what we mean by a digital vision. So next slide. And I'll skip over that one just in the interest of time. Thanks. Next slide. So our digital vision really is, we've been tasked with trying to, I suppose, identify the functionality that exists both in primary care and secondary care IT systems, as kind of Louise has kind of alluded to with her IT system at Oxford. We know that there's variety in the IT systems that are used both in primary and secondary care, and we're not entirely sure how much they do to support stewardship. So we've been spending a bit of time trying to scope out the functionality. And also there's a number of bolt-on packages for antimicrobial stewardship activities, principally in primary care, so things like Optimize RX or Ardens and similar examples. And there's a smaller number of those, or probably much fewer of those, in secondary care. So we're trying to understand what they do, and how well they work, and also to understand the gaps where they don't do maybe what people would like them to do. So as with the Oxford example, developing additional data analysis to support stewardship activities. So those workarounds that people have developed to fill gaps in their functionality, that the system that they have, are really of great interest to us. We want to be able to collect and share examples of that good practice. So this is a fantastic opportunity to do that, and Louise and Doug and team have done that really eloquently. But also maybe thinking to the future of describing, what is the core functionality that all of these systems and these IT solutions, what core functionality should they all have as a base, accepting that you can always get the bells and whistles version of a package, but there may be a more basic package that is in use. So what is the core functionality that all of those things have to support optimal stewardship activity? So next slide, please. So I'm going to speak about primary care, and then Laura's going to come in on the secondary care element. But it's all one big picture, if that makes sense. But from a primary care perspective, we know that the vast majority of antibiotic prescribing in England take place in primary care. It's almost 3/4. And as a result, and with the digitization of primary care, there's a real opportunity to leverage those systems to support, wherever possible, desired activities relating to stewardship. And we know that GPs are under enormous pressure, and I've put here data for GPs just because that's what's available, but we do recognise that there are many healthcare professionals involved in the patient journey in primary care. It's not just GPs who prescribe, but their average consultation time back in 2016 was shown to be 9.2 minutes. So really pressured time to do a whole host of things, and they spend about a quarter of their time multitasking during consultations. So there's lots of distractions, there's lots of problems with the IT, as well as all the complexity of the patient themselves. So all of those things will have an impact on prescribing, and there's a whole wider range of behaviors that impact on prescribing, because it is a human behavior to decide to prescribe and then to have to choose something and decide what you're going to do, and that they're influenced by socioeconomic factors, behavioral, cultural factors, patient factors, a whole host of things that we haven't got time to go into. So the question really is, what can our IT systems do to support that really pressured, really complex interaction between a patient and a prescriber? And are we using both the functionality that exists at the moment optimally, and how can we optimize it for the future? And we have to recognize that there is no one perfect IT system. They all have their own strengths and limitations. And also the evidence suggests that things like decision support tools only have a limited impact, because it's such a complex area, on improving desired processes of care. And this recent meta-analysis just showed a 5.8% absolute improvement. But actually, when you think of if 75% of prescribing is occurring in primary care, and we delivered a 4 or 5% improvement in that, that still translates to an enormous population benefit potentially. Next slide, please. Thank you. So we've done a bit of time scoping out the IT systems and looking at the literature, and what we've identified is there's 7 main functional areas of an IT system which relate to, the clinical aspects of an IT system, supporting making a diagnosis. I'm sorry, this dropped off the bottom of the slide, but patient-facing decision support tools, prescribing itself, administrative functions, reporting functions, and audit and performance and surveillance potentially. And this wheel is very much an early iteration, so please don't worry about trying to read the text. It is quite small. But on the inside, the innermost wheel, we have those 7 key functions we think relate to stewardship. And on the outer ring of the wheel, the outermost ring, is the bits within the National Action Plan for Antimicrobial Resistance that relate to prescribing, IT systems, primary care and stuff like that. So we've tried to relate each of the functional things we think are important to to an overarching strategy or position within the National Action Plan. So we're still working on that. So but within the inner wheels, you can see radiating out from the center, we've got where we think some of the key parts of functionality to explore further are. So those are our early phases. I'll hand over to Laura now at the next slide to talk about secondary care. You're muted, Laura.
You're just on mute, Laura. We can see you.
Okay, shall I take over, Laura? Do you want me to, if you haven't able to? Yeah, okay, so apologies, Laura's got some IT issues. So secondary care is, a really obviously big focus area for us. So we know that there's obviously a much smaller volume of prescribing when you think of the actual totality of prescribing within England. It equates to about almost 18%, I think. But of course, it's quite a different process in secondary care. So patients are obviously more complex. They're more unwell, obviously, hence their admission to hospital. We see a wider range of infections than maybe you would in primary care, and the complexity of those infections. There's obviously
I'm unmuted now, I think, if you want me to take.
Yeah,
sorry, I don't know why the delay. So as Connor's very eloquently put, there's again, this is the SBAR data. So about 6% of prescribing is in outpatients in hospital and 12% in inpatients of the sort of national overall prescribing. So smaller but more complex, as you said. I know we've spoken in previous presentations on the Start Smart Then Focus sort of guidelines, but this sort of view of prescribing in secondary care, it's a bit different to that very sort of high-pressured single-person consultation in 9.2 minutes, in that it's a very prolonged process with lots of different members of the multidisciplinary team involved, and sort of lots of time in hospital, and the patient's condition changes, and this standard review is needed at 48 to 72 hours, but there will be also other things happening like deterioration, patient improvement, results coming through that will impact on that patient's journey, and so those processes involved in patient care. We've got a wider variety of antimicrobials available and more types of infections seen in secondary care. So again, that sort of increases the scope of complexity somewhat. Bearing in mind, the Start Smart Then Focus guidelines sort of talk about individual patient management, and on top of that, in a similar manner to what we have for primary care, is we have the overarching AMS teams activities, which have been really nicely described by our colleagues in Oxford about the kind of things they do in an overarching way to help stewardship. And then again, the data, that's both for immediate patient management, but actually for active surveillance and quality improvement as well. So next slide, please. So this you may be familiar with, given the audience. This is the sort of digital survey that was information gathering survey for NHS Digital this year. about uptake of electronic prescribing in secondary care, and this was sort of dedicated towards medicines interoperability, but it does tell us some things about EPMA, that some people are still on paper systems. There was about 65%, I think, uptake when the survey was done of digital systems, so still some way to go to ensure that's universally adopted. And we see a much higher variety in the actual systems used. So whereas you can count on one hand for primary care the different systems that our primary care colleagues have to prescribe, it's sort of 20s, 30s systems available, and some trusts using, very much in-house bespoke systems. So there's a lot more variation. And again, each system might have different sort of levels different sort of levels in terms of how much of that system, are additional modules brought in and added on, or is it just a sort of basic system? And then, as we've seen beautifully demonstrated by Louise and colleagues in Oxford, in-house modification. So 2 trusts can be using the same system, but actually with very, very different results and abilities to work with this. So what do we plan to do for secondary care? Well, a big part of this is information gathering, which we're doing now and doing through in a more robust way through these surveys and focus groups about how can we and are we currently supporting stewardship digitally? What's missing? What are people having to work around? And what actually, because there's some things in digital systems that actually going from paper to digital has made harder. What are those? How can we help sort of iron out those glitches? And then we're going to aim to, in a similar way to primary care, prioritise these functional requirements, both of the prescribing system and then any digital decision support system. And it's about sort of sharing best practice. So can we parachute in what's happening in Oxford in other places with good effect, or are there other best practice examples out there to share? And so use all this to describe what digital vision should look like for secondary care. Next slide, please. So what are the next steps? So I've mentioned that we're doing 6 focus groups, 3 will be primary care and 3 secondary care. We really want a range of stakeholders. So we don't just want stewardship staff. We want people working in clinical informatics and digital sort of healthcare as well. And we want the front-end clinicians, because the needs of one group of staff aren't necessarily the same, and everyone will have different experiences and different priorities in terms of how to effect stewardship using digital systems. And then we're going to widen that scope out to a survey. So we'll be hoping there's lots of people on this call who will take part in this and really help us shape what needs to happen. I think Connor mentioned that we've already done software supplier demonstrations in primary care, and that is happening at the end of this process in secondary care, so a bit of a flip of way round. I'm going to hand back to Connor now just to round this up. Thank you.
Lovely, thanks very much, Laura. So next slide. Actually, just go back one slide. Sorry. Yep. So to that end, we are trying to pull together a stakeholder list of people who we would send out a link to participate either in focus groups and or a subsequent survey. And I've put in the chat as well. But if that's something that's of interest to you, please do get in touch with us. Our contact details will be on the last slide in a second. But also, so we're planning to run six focus groups, 3 for primary care and 3 for secondary care. So obviously we won't be able to get everyone in those, but we'll be taking the information and learning from the focus groups to build a survey, which will go out to a much wider distribution list. So again, as Laura's outlined, that we don't want that just to be pharmacy and pharmacists, as it were, and pharmacy technicians. We want it to be nurses, EPMA, people who work in EPMA, CCIOs, a really diverse range of people to participate either in the focus groups or the surveys. So look out for information on that. But as I say, we'll try to pull together a stakeholder list, but if you can volunteer names as well for that with people's permission, that would be very much appreciated. So next slide. So just to plug here, Tanya already outlined right at the start about World Antimicrobial Awareness Week, but just to say we have a number of webinars taking place during World Antimicrobial Awareness Week on different themes which are aligned to the daily themes of World Antimicrobial Awareness Week. These will be of interest to all sorts of healthcare professionals, not just pharmacy and medics, but nursing staff, IPC, laboratory staff, potentially both in primary and secondary care. So the link, I put the link to the NHS England events page in the chat as well, so you can click, and you just need to register for these. But if you can't make it during the day, on one of those days, you'll be able to watch it later in our future NHS workspace. We'll record them and upload them to the webinar, to the web space there. So next slide, please. So hopefully that's been of interest, and maybe we've whetted your appetite to maybe get involved and give us examples of your all singing, all dancing IT systems and stuff. And as I say, we will be trying to pull together a stakeholder list. If you want to have your name on that list, please, you can contact us. Laura's going to sort of be the contact for secondary care, and I'll be the contact for primary care. So do get in touch if you'd like to be added to our list. Thank you very much, Sangeeta, for the opportunity to present.
Oh, thank you, Connor and Laura. That was really insightful. I think what stood out to me in particular was, whilst we have a digital vision, not everyone's on the same level of the journey, because the adoption varies. But we've got a question that I hope you could potentially help with. So we've got a delegate who said that they've used EPMA systems and they've had little support with regards to antimicrobial stewardship. So nationally, what can we do to bring pressure to this problem and get suppliers to address this?
Yeah, so it's not going to be an overnight fix. I think that's the first thing to say, just to manage expectations. We have had a very useful discussion with NHS Digital earlier on this year, and asking questions about antimicrobial stewardship and where that all fits in with their program of work in terms of suppliers. So I think until we can develop a digital vision and specify the core bits of functionality that we think all IT systems have, we'll then take that back and say, look, this is something that you need to think about when you are commissioning or procuring contracts and for IT systems. And we know that with the software suppliers, their work programs tend to be, they're at least 2 years, filled up for the next 2 years at the very least. So this isn't going to be an overnight fix. But I think that's the way we feel that we'll influence, is by going back and utilizing this sort of NHS digital route to our NHS England route, I guess it is now, because it's all joined organisation. But you drive it from the top, as well as pressure from the bottom as well. So people feeding back to us about what works well and what doesn't.
Thank you.
I think the other thing is that as we get more information about what good looks like and how some people have gone further faster, we can also we can use that in terms of with our other data and metrics about antimicrobial use and infection management that are coming on board and workforce surveys to sort of create a bit of a map about how these might be beneficial, and then maybe that's possible to use that to sort of create some leverage to do things in areas of the country or trusts that haven't moved very far further, and we can help as your regional stewardship leads in terms of championing that and talking to the right people. So that's in addition to sort of finding the real best practice in helping share and spread that quickly, so things aren't happening in silos. So that's what we can do as well from an NHS England sort of standpoint.
Lovely. Thank you. Just the final question. What would you say is the one key takeaway message you'd like our delegates to take back to their organizations, regardless of sector they work in, to realize this digital vision?
Oh, that's a really good question. Yeah, get in touch with us, because we can't do this alone. So if there's people, they've got champions in their organizations or people who really want to participate, we want to hear from them, and we want to hear those examples of good practice. So if you're doing great work, shout about it and shout in our direction as well.
Lovely. Thank you very much, Connor and Laura. So I will just wrap up. We've had 3 lovely presenters today talking to us about the threat of antimicrobial resistance to our existence. We've also had some information from Louise, Doug, and Tig about tools that we can use in EPMA systems to enhance antimicrobial stewardship. And Laura and Connor have summarized to us what the digital vision should be with ePrescribing in the future. I want to take this opportunity just to inform all our delegates that our next masterclass will be on 14th of December. And if you want to get involved in the conversation, the hashtag on Twitter is ePrescribing Masterclass. Thank you very much for attending today, and I wish you all a good day. Thank you.